Okay, everybody, welcome to tonight's talk. The purpose of these talks that I give is to educate the public regarding kidney disease, to help people think about their own conditions and maybe their friends or loved ones, and to evangelize the public to please look after your kidneys and get the appropriate tests. So I'm hoping that after seeing a number of these talks, you'll know as much nephrology as your doctors do. That's the goal. So the title of tonight's talk is What You Need to Know About Your Kidneys. So just some facts, and this is more on the prevalence and the cost of kidney disease worldwide. There's about 8.5 billion people on the planet, but about 850 million people worldwide have some form of kidney disease. They're not, the majority are not on dialysis. And as I'll show you, kidney issues are a gradation from normality to where the kidney isn't functioning sufficiently to maintain your blood chemistry, and then you need dialysis. So the 850 million have kidney abnormalities over a wide range, but it includes all comers. And a disproportionate number of Americans are Hispanics and African Americans out of the total number of patients. So there's a disproportional representation of these folks when you look at a dialysis unit or a renal clinic. It's estimated out of the entire US population, there's about 40 million people that have some impairment in their kidney function. And about at any point in time, there's about 650,000 people on dialysis. It does vary. It varies among different racial groups. But in general, that's a number that you can keep in mind. And just to give you an idea of the expense to the US government, some of you may know that in the 1970s, a bunch of nephrologists went to Congress and said, we have this new form of renal therapy called dialysis, and it would be unethical for the United States government not to pay for this expensive care. At the time, they thought it would cost ultimately maybe $800 million to care for the US population, but the number now is staggering. In 2021, Medicare spent $114 billion on kidney care, which is about 1/8 or 1/9 of the entire Medicare budget in this country. So it's a huge expense for the federal government to look after patients with kidney disease. So now to segue into some of the other issues that you need to think of and things that people ask. The kidneys are situated towards the back. They're not in the front. So they're not halfway between in the front and the back. They're more in the back, and they each weigh about 1/3 of the pound. So they don't weigh a lot, and they're almost under the diaphragm, maybe a little further down. So here's one kidney, here's the other, and the adrenal glands that make your cortisol sit on top of each kidney. Now, this is an important slide that I've showed before, but I keep showing it because it's just something most nephrologists don't know, most doctors don't know, and patients forget. And that is, in normal, healthy men and women, one colors the men, one colors the women. It doesn't matter. Both these lines are roughly the same. But the important take-home point, and this is a plot of age and years versus kidney function. There's no units here, but you can take 100, let's say, as 100% of normal. What you see here is in perfectly normal people, there's an age-dependent decline in kidney function. And I'll talk about what function we're talking about, because when you talk about the kidney, it actually doesn't have one function. It has many, many, many different functions. But in general, people use this sort of global term kidney function without being precise. It's like the brain. The brain has many different functions. The kidney is the same. And we'll talk about some of those throughout the talk. But what you see here is this function of the kidney, and we'll be more precise as to what that is in a minute, isn't the same at all ages. It normally decreases, so that, at this age group, when you're 75, you could be down to, 75% or 25% decrement in your kidney function. And this was your eGFR. Your eGFR, instead of being 100, let's say when you're 50, will be 75 at this point in your life. And this doesn't represent disease. And that's a very important point, because as we'll talk about, when doctors talk to patients who have this kind of decline, they often attribute this to some underlying kidney problem. even though there's nothing going on. And some people are being treated inappropriately with medications where they shouldn't be treated at all. And it also has implications, as I'll show in a minute, regarding what CKD stage you're at, because the CKD stages are just a human way of categorizing what GFR you're at. And we'll go over that again. I went over it last month also, but it's an important point because it's confusing for people as to what tests they should look at when they're looking at their blood tests. So the take-home message from this slide, kidney function decreases with age. And the next point that I didn't mention is that it's important to know where it should be roughly, because only then, if it's worse than what it should be, do you call that kidney disease, or would you think of looking for kidney disease? Or if it's better than this, then you're fine. In fact, someone who's 75 with a function of 100 isn't functioning normally; they're functioning better than normal. That's the paradox. And the problem is, most primary care doctors aren't aware of this, and I would vouch to say many nephrologists aren't. So it's a point of confusion for patients, and doctors are quite surprised when you tell them. Okay. And please unmute if you have any questions throughout the talk. I'll leave time for questions at the end. So if you go to the doctor and you look at your lab slips or your electronic medical record or my chart, whatever you look at, you're going to see three words that refer to what your kidney function is. One is creatinine, and this is not creatine. So don't make a mistake between creatine and creatinine. They sound the same, but they're very different, just as different as a bird is from a tree. They're very different. So the word is creatinine. Then there's something called eGFR. And then there's something else called CKD stage. Now I'll go through each of these. The take-home message before I get into the weeds is that they're all telling you the same thing. So this is very confusing to people. They think that this is something else medically indicated by looking at these three things. It's not like other tests. They all are telling the same story. They're just different ways of saying it. And you could justifiably ask, why do we have these three things? I mean, in the 1950s, 60s, and 70s, and 80s, we just had the creatinine. The GFR wasn't an eGFR. E stands for estimated. We'll talk about that. We measured we determined the GFR separately with a test that required some radioactive substance put into the body, not a big dose, but it fell out of favor. And now we don't measure the GFR anymore. We estimate it using a mathematical equation, but that equation is based on the creatinine and the patient's age. So really, we're using the creatinine again to calculate the eGFR. And the CKD came about in the 90s and in the 2000s, where people said, well, we have different GFRs or eGFRs. Let's subdivide those into different apartments. And we'll call group 1 a GFR of this range. And we'll call group 2, or CKD stage 2, another range of GFRs. But the point is, this is an arbitrary human creation. The GFR declines from being 100% of normal down to theoretically 0 in a continuum. It's not something that jumps. I think in a certain sense, creating the CKD stages did a disservice to patients. It creates confusion, and they focus in on this like it's gospel. It's not. It's just subdividing a range of values into a name that was given. But it's not saying anything new. It's not giving any more information than what the eGFR is. Now, the trouble with the eGFR versus the GFR, remember this little e here, which means estimated, is it's not a measured value. The only thing that's measured on this slide is the creatinine, which everything is based on. The GFR, we don't measure it anymore, as I mentioned, is estimated by a mathematical equation that includes creatinine and other factors. So the reason it's important to know that it's estimated is that it's not, again, not gospel. This number can be off by 15, 20% in a person. Someone who has an eGFR of 40, well, it might be actually, 55, 58, whatever the error is. And you just don't know. We're working now with a company on trying to come out with an actual measured GFR for the first time in 30 years. And I think it's going to be something that hopefully will significantly improve the care of patients. But that's a story for another day. So let's look at the blood tests now, which is the only thing on the last slide that is actually measured. And it's the creatinine. And the creatinine has been around since, I don't know, the 1940s, 50s. It's an outstanding test to assess kidney function, and every human on the planet should know what their creatinine is. And just to give you an example of how to think about it, when the creatinine is 1 or near 1.9 or 1.1, that sort of thing, but when it's near 1 in the units we use here, that represents kidney function of 100%. Or if you want to think about it, an eGFR of 100, roughly, or a GFR of 100. When the creatinine doubles, it seems like a small change, but you actually lost half your GFR from 100 to 50. As a general rule, it's not exact, but it's the way to think about it. You take 1 over the numbers. So if it goes to 2, 1 over 2 is half. That's where the 50% comes from. And if it goes to 4, 1 over 4 is a quarter or 25%. So every time it doubles, you've lost half of the previous percentage. Okay, so the creatinine is used to assess kidney function. We knew this before eGFR came about or GFR came about, and we knew this before CKD stages. So there's nothing new with these other numbers. So please don't get confused by it. And this just shows the mathematical relationship. This is a confusing slide, a lot of information on here, but please focus on the green curve. Focus on the x-axis here, which says glomerular filtration rate, which is what GFR stands for. GFR is an acronym, taking the first letter from each of these, the G, the F, and the R. So GFR, eGFR, because it's estimated, not measured. And it goes, let's say on this slide, from 0 to 120. And this is the creatinine on the y-axis. So you can see that as your creatinine goes up, or as your GFR goes down, you get this curve. So as the GFR declines for whatever reason, your creatinine goes up and up and up and up. And you can see that when you go from 120 to 60, which is a 50% decline in your GFR, your creatinine, goes to 2, it doubles. It doesn't look like a lot. When your GFR goes from 60 to 30, the creatinine changes a lot more. You've only lost 30 in these units, mils per minute of GFR. You've already lost 60, and the creatinine doesn't change much. You lose another 30, it changes more. You lose another 15, it changes even more. So the change when you have low GFRs looks greater, and it really scares patients, because very little change in GFR when you get into this range can have a much bigger effect on the creatinine. It's just because it's a hyperbolic mathematical function, and a hyperbola has this shape. So patients, come in and say, oh, my creatinine went from 2.5 to 4 or 5. I'm really in trouble. And that what the doctor should be saying is, no, you lost most of your GFR when it went from 1 to 2. So that's another confusing part, which is part of the reason why giving the eGFR in addition to the creatinine, both for doctors who don't know nephrology that well and for patients, the numbers change a lot more when you show the eGFR. So it gives just emotionally a much better feel of what's going on with the kidney. When it goes from 1 to 2, even though you've lost 50% of your kidney function, the change is so little that people and also doctors don't recognize it when your primary care doctors don't pay attention as they should in this range. When your creatinine goes from 1 to 1.5, a good nephrologist would say that's a problem, but the primary care doctor may not even notice it because the change is so little. So these are just some of the subtleties to think about when you're assessing your eGFR or your creatinine, but just realize that the creatinine is the measured number. Now, the third thing, the CKD stages, came about also, which made it even more confusing for patients in the last 25 years, because all they did was divide up the GFR into these different apartment buildings. It's not saying anything new. Before the CKD staging system was created, we just looked at the GFRs, and if it was 90, it was 90. If it was 85, it was 85. It's a continual change going from normality here to less than 15. 15 is sort of a cutoff because that's when your kidneys are no longer able to maintain your blood chemistry normal. And that's when you need what we call renal replacement therapy, which is either dialysis or a kidney transplant. So what you can see from this slide is that there's a huge redundancy in the kidney's function. You don't get into trouble until you get down to, maybe 15% or 10% of your original kidney function. Above that, your kidney's still able to provide enough function to keep your blood chemistry the way it should be. Okay, so big backup. And again, we're talking about the function of both kidneys together. Now, it's interesting because in a normal human or a kidney donor, if you take out one kidney, you would think the GFR would go to 50, or your eGFR would go to 50, right? You have half the function. But what turns out over the next year or so is that the remaining kidney starts getting bigger and bigger and bigger and bigger, and it actually can take over the function of both. And the eGFR over the year gradually climbs back up. You get this immediate fall after the donation, and then starts climbing. And in fact, in an animal, if you put a third kidney in, the remaining two actually shrink. So you can't get more bang for the buck by putting in an additional kidney. So when you get kidney disease, no matter what the cause, and depending again on the severity of the decline in your GFR, you get a number of things happening. And this isn't due to a given cause of the kidney problem. This is sort of generic for all causes of why the GFR, and there's hundreds and hundreds of problems that the kidney can have clinically. So one is that you'll see, and I'll talk about why you get these in a few slides. So fluid overload with swelling of your feet. Unexpected is changes in your appetite and nausea. You actually feel like throwing up if it gets very severe, or nauseous. Your blood pressure can go up. You get what we call electrolyte disorders. And these chemical symbols refer to different electrolytes in your blood. Na is sodium, K is potassium, Ca is calcium, Mg is magnesium, P is phosphorus, HCO3 is bicarbonate, or what you have in Arm & Hammer baking soda. These things can change when the kidneys don't work well. You can get anemic. We'll talk about that. You can get depression. You can get symptoms that mask depression, even though they're not truly depression. And it's incumbent on the nephrologist and the social worker to decide whether you're truly depressed or not. And there's quantitative ways of doing that. The big area of confusion in nephrology where people are told they're depressed and they're not, and vice versa. You can have sleep disturbances where you feel like sleeping during the day and you stay awake at night, or just haphazard, and then abnormal taste of your foods. So these are some of the common things patients with severe kidney disease complain of. And again, they're non-specific. You can get these in other medical conditions. So when we're looking at the creatinine, and when we're testing for the creatinine, and when we're looking at eGFR, not shown here, and when we're talking about CKD stage, we're talking about a portion of the kidney called the glomerulus. Now, this is one functioning unit within each kidney. You have 1 million of these in each kidney. The glomerulus you can think of as a filter, or the bathtub drain in your bathtub. The rest of this thing we call the kidney tubule, or the nephron. You can think of this as the pipe coming out of your bathtub after the filter. So we have these two major functional categories in the functional units of the kidney. Again, this is 1 out of 1 million in each kidney. The sum total of all these filters is what gives you your eGFR. The eGFR is the amount of fluid coming through all 2 million of these filters. So normally it's around 100. So when you think of what the eGFR represents, you're actually asking how much fluid is coming through the drain in my 2 million bathtubs. Okay. And then after the filter is something called the nephron that does what we call the electrolyte transporting and water transporting functionality of that portion of the nephron. So there's a filtering part and there's a transporting part. And at the end of all this comes out the urine that we pee out in the toilet. When the creatinine goes from 1 to 2, you can think of it that you lost half of your filters. So it went from 1 million to 2 million, depending on what you started with, as a general idea. When you went from 1 to 4, you have a quarter of the 2 million original filters. And that's what your EGFR is. EGFR just tells you how much you're filtering. So if the EGFR is 100, the 2 million are working fine. When the EGFR is 50, you have half of them working. That sort of thing is a rough idea. But again, remember, the EGFR is estimated, so you can't really know from the EGFR exactly what number or percent of the original number are filtering. It's just an estimate. And again, when you get down to 15% of the 2 million functioning normally, you really need dialysis. Now, this functional abnormality could be due to many, many different diseases. And it can also, within a disease, be reversible or not reversible. So it doesn't mean that it's permanently decreased. We have something called AKI, or acute kidney injury, which we see in the hospital when people have a heart attack or get certain drugs. The kidney abnormality can reverse after 6 or 7 weeks. They might need to be dialyzed depending on the severity, but it's short term. It's not permanent. We don't call that a CKD stage. C stands for chronic. It means it's not going to reverse, or at least reverse currently with the medications that we have. So in addition to the creatinine, the EGFR, and the CKD stage, which refers only to the filter, not the rest of the tubule or the nephron, we have other things we test for. We test for protein in the urine. Protein in the urine is also a test of the filter, but not that the filter is working less than normal. It's actually letting protein through into the rest of the nephron and finally into the toilet, because this filter should prevent protein from getting through. So the fact that protein is coming through is telling us, again, there's something wrong with the filter, independent of what the creatinine is telling us. Creatinine is telling us how much fluid is coming through, and that gets decreased and decreased. But this is sort of the opposite. There's excessive protein coming through. The reason there's bubbles here is bubbles are a sign that there's protein in the urine. This confuses people because the most common reason for bubbles is that you peed from too high above the water. You just created air. But if you're peeing close to the water and you have this, it's worth checking whether you have protein in the urine. This is just a stick in the doctor's office that has different squares here. Each responds to different amounts of protein. You can also have blood in the urine. This filter should not let red blood cells through. Remember, we have 3 different types of cells in our blood: red cells, white cells, and platelets. Red cells should not get through into the urine. If they do, there's something wrong with the filter. So this is obviously more and more blood. You can still have blood here, and that we would see under the microscope. So when the urine is sent off, it's sent also off for microscopy, and the technician counts the number of red cells under a certain field in the microscope, and above a certain point, we say, yes, there's blood in the urine, but we call that microscopic because we can't see changes grossly. And it's basically an early warning sign that there could be a lot more blood coming in, or some people, depending on the kidney disease, have microscopic blood in the urine their whole life. We also check the urine for infections. Very common in sexually active women in their 20s and 30s to get urinary tract infections, and also elderly women because of the changes in the tissues in the urinary tract. And so what we do is we take urine, we put it on what's called a petri dish, which is basically food. It's a jelly-like substance that hardens, and there's food in here for the bacteria. We put the urine on, and we look for these little colonies, these little Blebsia colonies of bacteria growing. And here we're seeing the bacteria in the urine under the microscope. We do this because from this we can't tell exactly what type of bacteria it is. There's hundreds of different bacteria. This tells us not only that we have bacteria, but the type of bacteria, because we can put little discs of antibiotics here, and that will tell us also whether the colony is sensitive to a given antibiotic. Typically, a person will come in, young woman with burning, peeing a lot, and most likely urinary tract infection. And the doctor will put person on an antibiotic and guess what the urinary tract infection is due to, and wait 48 to 72 hours for the definitive answer as to what the antibiotic sensitivity is. Sometimes the antibiotic is wrong and the antibiotic needs to be switched. Oftentimes, too, people start antibiotics before the urine is cultured, and that's a problem because that can suppress the growth. Even if the antibiotic is not perfect, it can still suppress the growth. So it's best to put urine on that has where there's no antibiotics in the person's body. We also in the urine look for what are called white blood cells. These are inflammatory cells. This is what's in pus when you get an infection. This type of cell should not be in the urine. So if we see it in the urine, it tells us that there may be a urinary tract infection. There are many, many, many kidney diseases where this can be in the urine also that are not due to infection, which we won't get into today. So what are some of the, so we talked about how we test for kidney problems. What are some of the diseases that affect the kidneys? Well, the elephant in the room is diabetes. So if you got rid of what's called diabetic nephropathy or diabetic kidney disease, you'd rid the world of half of the kidney problems. So the 800 million will go down to 400 million. The 40 million in the United States will go to 20 million. You'd empty out half the dialysis units and you cut the transplant programs in half. So the big cause of kidney disease is diabetes. The lay public tends to think of diabetes as a sugar problem. That is true, but the problem with diabetes, both in general and for the kidneys, is it's not the sugar that is the problem that we're dealing with. We're dealing with the fact that diabetic patients get blood vessel problems. And one of the goals to be a human is to keep your blood vessels normal throughout your whole life. And diabetes is one of the diseases that can injure the blood vessels. And what it does is, instead of having a nice blood vessel like this on the left, the inside of the blood vessel fills up with cholesterol and fatty deposits. That's the yellow. Plus, you can get blood clots forming with platelets here. Just like, when you cut yourself and you get a scab, this is a scab in the vessel. And both of these things do one thing. They lower the luminal diameter. You need a certain diameter to allow the amount of blood cells to come through here at the right flow rate. It's like a hose. If you block the hose, you're not going to get the water coming out normally. The same thing is occurring with these blood vessels. And if this occurs in one of your coronary arteries in your heart, you can get a heart attack. If it occurs in the blood vessels in your brain, you can get a stroke. And if it occurs in the kidney, you're going to get less GFR. That's one problem. But the second problem is in diabetes, the filter itself that I showed on the previous slide. Just go back for those. They need to be refreshed as far as reminding them of what I'm talking about. This is one of the filters. Diabetes screws up this filter, fills it with protein and makes it filterless. And what's shown here is just a cut through one of these filters. So it's a two-dimensional cut of a three-dimensional object. You can think of a soccer ball that you've cut and then shown it on a slide. And it's stained with a certain dye so you can see it. So these are all the different components of the filter. It looks like a bathtub drain with everything nice and open, just grossly for the uninitiated. And you can see here, the diabetic one is filled with this purple stuff. So you can imagine it's not going to filter normally. And, this is occurring in all 2 million of the filters. And so, if it's mildly effective, your GFR will go from 100 to 80. If it blocks half of the holes in the filter here, it'll go to your eGFR will go to 50, that sort of thing. This takes about 18 years to go from here to here when you have diabetes. It does not occur in all people who are diabetic. If you have diabetes, we divide diabetes into two types. Type 1 means that your pancreas is not making insulin normally. And so we call that insulin-dependent diabetes or type 1 diabetes. 40% of those people have a kidney problem. The second type is called type 2 diabetes, where you have enough insulin, but the problem is insulin can't work normally. And that happens when you're too overweight. So being overweight is often associated with type 2 diabetes, not because you don't have enough insulin, but because you have enough. And in fact, the pancreas is putting out more than normal, but the insulin doesn't work on the cells normally. There's a whole complicated biochemistry that occurs. We won't get into that today. When you get overweight, you impair the function of insulin. That's what that's about. And it's reversible too. That's the sad part, that if you just lose weight and get back to your ideal weight, your type 2 diabetes goes away. And this, if it's too late, won't go away. That's the problem. And by far in the United States, the most common form of diabetes is type 2, just because we have a national problem with people being overweight. So, and that's the sad paradoxical part, that if the population in general could lose weight, we would have a lot less type 2 diabetes. So totally reversible, and due to the fact that human beings love food. So the problem here is twofold. One, it's a blood flow problem, like your hose not working, just the diameter of the blood vessels gets narrow. Plus you get this stuff clogging up the filters. So diabetes. Another big disease, especially in Southeast Asia, is called IgA nephropathy. This is an inflammatory process. It usually presents after a cold or upper respiratory tract infection, and then a day or two later, patient says, I just started peeing and it was blood. I just saw blood coming in my urine. And we do a kidney biopsy, and we see this green material in the glomerulus. This is called an antibody, and it's what is created when you get a vaccination. Not that that's bad. I'm just saying antibodies are what protects you. But these people are making antibodies against their own tissue, and the antibody is called IgA. And the tissue happens to be the filter again in the kidney. So they make this abnormal IgA, and it attacks the filters. And you can see in response, there's all these purple things. These are inflammatory cells that are just, you can see there's no holes here. It should look like this. And it looks all congested, and it's actually swollen. And this is what we see, IgA nephropathy, most common form of an antibody attack on the kidney in the world. Kidney stones, the kidney doesn't have a problem with the filters or the tissue itself, but you can get stones formed in the urine. And that affects 15 million Americans. There's different type of stones: calcium phosphate stones, uric acid stones, xanthine stones, cysteine stones, many different types. They just look like a stone, and they can be different sizes, and they can occur in different places, and they can occur in different amounts. And the treatment can either be ultrasound to try to destroy this thing with sound waves, or the surgeon might have to go in with a laser and pulverize it. Many different ways to deal with it. It can be on one side, both sides. You can also get calcification, like a salt and pepper like appearance throughout the kidney. We call that nephrocalcinosis. It's not actually a big stone where the urine is being created here, but within the tissue itself. This is another big disease. About 10% of people on dialysis have it. It's the most common genetic disease that affects the kidney. It's called polycystic kidney disease. You only need one parent to have it, not both. So it's not like cystic fibrosis. It's not what we call autosomal recessive. Autosomal dominant, one parent, you can get it. And so the kidneys, instead of looking nice and horseshoe shaped, have all these blebs coming out. Tons of these blebs, and the kidney gets bigger, also the size of a football here. These blebs may not start occurring until you're in your 40s or 50s, and your creatinine may be completely normal to your sort of the middle age part of your life. So people don't realize often that they have it, and there are problems for families also, because let's say a mother or father does have it, and they're afraid to get their kids tested. They don't want to find out that they have it, because that could impact their ability to get the health insurance, at least some insurance. So it's a major issue still. There's another disease tends to occur in young women more than men, called lupus, that you might have heard of. This is, again, an inflammatory attack on your own tissues. It doesn't involve just the kidney. It can occur in any organ in the body: brain, eyes, skin, every organ can be involved. You can see here, we call this a malar rash. This is not a sunburn, the blood vessels under her skin are actually dilated from the inflammation. So you're just seeing more blood flow here. It's not something in the skin. Again, we go to the kidney. It's the filter which is being attacked. This is a normal filter, nice open holes here, loops, where the filtration occurs. Think of it just like a filter in your bathtub, 2 million of these, and this is hers, filled with inflammatory cells. So you can see how this thing's not going to filter normally. Her eGFR may be 20, I have no idea. And the glomerulus gets swollen. You can see how much bigger it is than this one. Basically, it's inflammation of the filters. And like all organs, you can get kidney cancer. This shows a cartoon of a cancer here. This is the left kidney. This is the right kidney. And this would be a normal horseshoe-shaped kidney. And you can see within this kidney is this stuff that shouldn't be here. This is cancer. It's a pretty rare cancer, actually. We have different ways of dealing with it. We try not to take out the whole kidney, depending on the size, because we want to save normal kidney tissue. We take out the whole kidney, the eGFR goes to 50. Creatinine goes to 2. We take out a small part where the tumor is, the eGFR and the creatinine won't be affected as much. So we try to do minimally invasive type of surgery. They also do radioablation, where they put radio frequency waves into the tumor and just kill it from heating it up. There are many ways to deal with it. And not all masses in the kidney are malignant. It could be a benign mass. So it's a whole field in and of itself, how to deal with kidney masses. Now, changing topics now, let's look at the dialysis data in the United States. So this is sort of an easy way to remember it. At any point in time, if you take a snapshot, and this is again just an average, there are about 650,000 people on dialysis in the United States at any point in time, and about 100,000 new people go onto dialysis. So they had CKD stage 5, and their GFR was such that they weren't able to tolerate all the factors I mentioned. They had swelling or nausea, whatever it is, the doctor decided to put that they really need to go on dialysis now. And about each year, 100,000 people die. So the input and output are roughly the same, and we sort of have a steady state. Although in the last year or so, there's been, for the first time since UNO started keeping the data, a decline in the total number. The trends are declining. Dialysis units are closing. There's many potential reasons people come up with for that. Number one, during COVID, a lot of people with CKD stage 5 weren't getting the appropriate care because healthcare systems were focusing so much on COVID that a lot of patients weren't getting appropriate cancer care, cardiac care, or other care. And some people hypothesize an excessive mortality, a greater than normal mortality than normal in people with CKD5. So they didn't even have a chance to get on dialysis. And that's why the number might be declining. The second factor is transplant programs are transplanting people at a higher eGFR than they would have normally. Programs used to wait till the eGFR fell from 15 to 20 before patients would get a transplant. Now they're transplanting people from 20, 25, sometimes a bit higher. So it's an issue because it's good for the patients, and there's less people needed on dialysis because of it. So that couldn't be another reason why there's a decline in the total number. And then finally, we have new drugs coming on board. It's always a question I get asked, are there any new drugs that can prevent me from going from CKD stage 2 to 3 to 4 to 5? And this is an area of active research. And there's some new drugs on the horizon that I talked about in previous talks called SGLT2 inhibitors, and they may be making a dent, although some people think it's too early to invoke them as a cause of why. But ideally, this number, we would get this number down to as low as possible, and also at the same time try to prevent people from dying when they're on dialysis. The death, by the way, is not due to the dialysis. It's not due to the kidney disease. It's due to cardiac problems. People who are on dialysis who lose the necessary function of their kidneys have a much greater chance of getting coronary artery disease. It's a cardiology problem. In addition to the fact that half of them are diabetic, and diabetes affects the blood vessels in the heart, so there's a progression there. And thirdly, Many of these patients are not getting appropriate cardiac care. The nephrologists are not referring them to the cardiologist, so they're not going for their appointments. The cardiac care for this population needs to be significantly improved. In fact, should be occurring prior to going on dialysis at CKD stage 3, 4, and 5, should be plugged in with a cardiologist. So if you need to go and have what we call renal replacement therapy, one of the forms is called hemodialysis. And these patients go to a clinic typically 3 times a week, so either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and they're dialyzed for 3.5 hours, and they go home. Some people do it at home. It's called home hemodialysis. Either they get a technician at the cost of 40 or 50,000 a year, or they put the needles in themselves. So this is, to do it at home is pretty rare, even though the US government would like to see more of it, because it's obviously less costly if you don't have to support a whole dialysis unit. So hemodialysis. Little cartoon, I do sympathize with you, sir. I'm afraid you can't take your hemodialysis machine on the airplane. So this is a problem. If you need dialysis in a different city, the doctor with the dialysis entity just plugs you into a unit and your EMR is transferred. So it's usually not an issue unless you're going to a very small place, far way out place that doesn't have dialysis services. The other form of dialysis has nothing to do with needles, has nothing to do with a dialysis unit, and is called peritoneal dialysis. There's a sac underneath the muscle layer of your abdomen that's normally collapsed, like a balloon that's collapsed. But you can put fluid in it and it can blow up. You can put about imagine a 2-liter Coke bottle. You can fill it up with a 2-liter Coke bottle and it expands. And so in the 1970s, what came into play was this idea of using the peritoneal membrane as a dialyzer. And so fluid is put in, kept in for 2 hours, takes the poisons out of the blood, and then the fluid is removed and another bag goes in. And this occurs automatically while people are sleeping, about 4 times a night, maybe 5 at the most, each 2 hours in duration. So the patient hooks up before they go to bed and they unhook when they wake up in the morning. They have to do it sterilely with a mask and gloves, just to make sure that you don't get an infection here of the fluid. The US government expects 1 infection every 4 years, roughly, in a good program. Peritoneal dialysis is great. It's what most nephrologists would want to be on if they needed dialysis. You can do it at home. You can do it alone. It's more private. You do it while you're sleeping. It doesn't interfere with your life. And you don't have also, because it's done every night, you don't have the huge swings that you get in your cardiovascular system if you're done 3 times a week. It's a very aggressive treatment because that 3 times a week is trying to replicate what the kidney's doing. The kidney's working 24/7. So it's not like your brain. Your brain comes up with the idea of how many hours a week you're going to work. You're going to take a rest on the weekend. You're going to take a vacation, or you're depressed and tired. The kidney doesn't know any of these concepts. It's working throughout your life around the clock. So obviously doing 3.5 hours 3 times a week is a very small amount of what you actually need. So the fact that this is done every night means also that it can be done more gently. So it's just easier on your physiology than hemodialysis. Or you could add a kidney transplant. Common question is what happens to the other kidneys? They're left in, and I'll talk about why. But the bottom line is that the kidneys do more than filter. They make hormones, and we don't want to remove that hormone production if we don't need to. It may not be normal, but we want to get whatever we can out of the remaining 2. So 3rd kidney is put in here. Different location than the other, more towards the front. So the kidneys have multiple functions. Again, repeating what I said before, the functional unit of the kidney is called nephron. We have about 1 million nephrons in each kidney, composed of a filtering component and then a electrolyte transporting and water transporting component that creates the final urine. The urine is a very complicated set of chemistry. It's not just water with some yellow substance in it. It's a very complicated chemistry, but if someone says to you, what does the kidney do? Some people will say it gets rid of poison. Some people will say it's a filter. If you want to give the correct answer on an exam, the answer is the kidney's purpose is to keep the chemistry of my blood constant, despite the fact that 3 times a day, I'm significantly perturbing my blood chemistry by eating. So when you eat, all the organic and inorganic and electrolytes and all the substances are being absorbed from your gastrointestinal tract into your blood. You're really significantly perturbing your blood chemistry if you can go back to grade 11 or 12 when you took chemistry. And if that continues without something bringing it back to normal, you're not going to be on the planet very long. So it's the kidney that actually recognizes the thousands of substances that you put into your bloodstream every time you eat, and gets rid of the appropriate amount, so that we end up with what's called a steady state, where the chemistry in the blood stays pseudo constant because the kidneys are recognizing everything that needs to come out. And it's the tubule part, the part that you can think of as a pipe, that does all that. So the kidney, as you might imagine, is imported for getting rid of water. If you drink 1 liter, the kidney gets rid of 1 liter. If you get rid of 3, if you take in 3 liters a day, the kidney gets rid of the 3. If you take in 4 liters a day, the kidney gets rid of 4. People think that by drinking, you could do something to your body, but it really depends on what time period you're talking about. Yeah, you're doing something prior to the kidney getting rid of it. But if you throughout the day drink 3, 4, 5 liters of water and your kidney gets rid of the 5 liters, you're basically taking the water that you bought and putting it into the toilet. Now, that brings up the question, how much water should a person drink? And that's a complicated question. You get all sorts of answers from all sorts of doctors. And the bottom line is you should drink when you're thirsty. You should not be driving the system. The only time you should drive the system, because your body knows exactly how much water you should drink. That's why we were given this gift of having the emotion of, I'm thirsty. When your brain is saying I'm thirsty, it's actually because your blood osmolality, which is the concentration of things in the blood, has gone up by 1%. It's very sensitive. And so when you're not thirsty, you don't need to drink unless you have some abnormality in your brain that can't sense thirst normally. I'm not talking about people like that who've had a stroke, or other people with issues going on inside their brain. The only time you really should drive the system, in other words, take water when you're not thirsty, is if you're exercising and you're losing a lot of sweat, or you anticipate you're not going to have access to water because you're on a flight for a long period of time, that sort of thing. But in an average day for an average person, you only need to drink when you're thirsty. Now, another important substance the kidney takes care of is called potassium. And, the cartoon says, and this dish is totally potassium free. There's nothing in the dish. And the reason for the cartoon is that almost everything has potassium in it. Potassium is in fruit, it's in meat, fish. Those are the big ones. Anything that has protein has potassium, and that's because potassium is highest in cells, and meat is muscle cells. Okay, and fruit are fruit cells, and they all contain a ton of potassium. Same with the cells in our body. The concentration of potassium in the cell, every cell in our body, is about 20 times what it is in our blood. So anything that's coming from cells, whether it's fruit, fish, meat, muscle cells, is going to be a source of potassium. Now, why is that important? Here it just shows bananas. If you go home and have 10 bananas tonight, you're going to get a huge potassium load. Why is that important? It's important because the blood potassium needs to be kept within a certain range. If you ingest a lot of bananas or anything, or tons of meat, whatever it is, acutely, 10 hamburgers tonight, and I'm just joking, but if you have a huge potassium load, your blood potassium cannot be allowed to change significantly, or you're going to have a problem. And what is the problem? Well, the blood potassium determines the electrical activity of cells. All the cells in our body have a voltage, just like a battery, around -20, -30 millivolts negative inside. Now, the most important cells that have a voltage, and where the voltage is changing every second, are the so-called pacemaker cells in our heart. So every second, the voltage in these cells is going up and down by a significant degree due to fluxes of ions in and out. We won't get into that. But without that, your heart won't contract. So the muscle first has to see a change in the voltage here. And every second that voltage is changing, so let's say it changes 60 times a minute, excuse me, your heart will then beat. So the muscle responds to the voltage change. It's like, you can think of your car won't run unless you press on, or a light won't go on unless you have a battery. The heart's the same. it can beat, but it only beats if the electricity changes appropriately. The teaching point is that potassium significantly changes the electricity. And you can actually stop someone's heart if their blood potassium goes too high. In fact, that's how on death row, some of the prisoners are killed. They inject potassium into the vein and stops the heart. So potassium is really important, and we can't just have an input from our diet. We have to have something regulating the potassium, bringing it back to normal, and that's our kidneys. The kidneys recognize the excess potassium coming in, and they get rid of it in the appropriate amount. Now, there's a whole complex machinery in the tubular part that I talked about that accomplishes that. So when you ingest 300 milliequivalents of potassium tonight for whatever reason, and I measure your 24-hour urine output, there'll be 300 milliequivalents of potassium in your urine, just the exact amount that is needed to match your dietary input. The other thing the kidney does is it gets rid of what's called nitrogen. There's nitrogen that's in hot dogs, meat, especially meat, just shown here for making the point are a bunch of hot dogs. But so nitrogen is in protein. So when you say I'm going to eat protein, you're eating nitrogen. Okay, it's a component of protein, and your nitrogen in your blood cannot go excessively high, or it causes other problems. And the kidneys get rid of the nitrogen. You might have seen those of you who look at your EMR blood tests a lot of the kidney. There's something called BUN, or some people call it BUN. It's an acronym. It stands for blood, urea, and nitrogen. The kidney gets rid of the nitrogen in the form of this compound called urea. That's what urea is. Urea is used for a fertilizer. They take the urine of cows or whatever, and they isolate the urea and they give it to plants. It's a great fertilizer because it contains nitrogen. That nitrogen, though, was the nitrogen excreted by the animal in response to the protein that it took in. We do the same thing. Now, what about high blood pressure? The kidneys control your blood pressure. They're probably the most important organ for what your blood pressure is. And they do that because they excrete salt, table salt. And this is just a little cartoon. The patrons at table 5 want to know how you manage to get such a wonderful taste in your salt-free soup. So salt equals blood pressure, elevation of blood pressure. In fact, you can dial in someone's blood pressure just by changing their salt intake. And many Americans, 45% of Americans age 18 and older, have high blood pressure. The limits keep getting redefined. There are two numbers. The top number is the pressure that you have in your blood vessels when your heart beats, just when the beat occurred. But after the beat occurred, the pressure doesn't go to zero. There's still a remaining pressure. That's the low number. And both are important. And so they have cutoffs for different age groups for what the high number and the low number should be. And everyone should know what their blood pressure is. And the problem with blood pressure is it's like the weather. It varies throughout the day. It's never the same. Varies at night too, but we don't measure it. The typical curve, we call it a diurnal variation, is that the blood pressure tends to start going up around 3-4 a.m. in the middle of the night, and then increases and increases, and then starts going back down towards the end of the afternoon. That would be a typical profile. When you go to the doctor will always get a higher reading than you get at home. It's called white coat syndrome. People are afraid to go to the office. They're nervous. There's a whole bunch of reflexes that occur, and the pressure goes up. A good doctor will never care about what your pressure is in the office. Now, they'll only care if you're not measuring it yourself. So you should be measuring your pressure throughout your life, making sure it's within normal limits, and know what it is also, at least at different parts of the day, because you can't assume if your pressure is normal in the morning, it's normal in the evening. So at a minimum, get it in the morning, afternoon, at night, at least for a number of days. And if it's always roughly the same, and it's the same from week to week, you don't have to become obsessive and focus in on it. It's only for people that are on new blood pressure pills, elderly, by that I mean people 75, 80, 90, they have excessive responses to blood pressure pills and can actually faint and collapse and break a hip. So we don't treat blood pressure in the elderly with the same degree as we do in younger people who can tolerate it. The other thing to realize is it varies not only throughout the day, but it also varies depending on what your posture is, whether you're lying, whether you're sitting or whether you're standing, you get a different pressure at the same time of day. So you can see it's very confusing, and people aren't told this, and they don't really know the time dependence or the posture dependence, but you should. And remember that whenever you get a pressure, you should know what time of day it was and also your posture. I tend to tell people just get it at the same time of day and get it, at least initially, and get it at the same posture. If you're going to only do one, you don't want to do more. Do it lying, do it in the morning. If you're more aggressive or more inquisitive about knowing what you have, do it in the afternoon lying, do it at night lying. The other thing is the blood pressure cuff is not perfect. So get at least 2 in a row. Take your pressure, write it down, or if you're Bluetoothing it or keeping it on your phone, whatever, just record it somehow, and then get another one right after and take the average of the 2. That's what you write down. You don't write down just one number because you may not get the same number. The other thing you should write down, which no one does or very few people do, is your heart rate. Okay, because the heart rate also is important, both because it can change with different blood pressures, plus a number of the pills, some of them we call beta blockers, lower the heart rate. And so you really want to write down the heart rate too at the same time, which people aren't aware of. So we can spend a whole hour on blood pressure, but I think if you can remember those things, and remember that the kidney is important for controlling pressure, and for a given pressure, even if you have high blood pressure, just by changing your salt intake, you can dial it up and down. If you take in more and more and more salt, the pressure will go up. You take less and less and less salt for the same clinical diseases. You can dial your blood pressure up or down with salt. A lot of people say, well, I don't add salt to my food. So the next question is, how much salt is in the food without adding it? Because some foods have a ton of salt. So it isn't just sufficient to say, I'm not adding salt. You really need to know the salt content of what you're eating. And I realize everyone loves salt, but the problem with it is most people don't know they have high blood pressure, because having high blood pressure from being on too much salt, you don't feel anything. Or even if it's not due to salt. I'm not saying that all high blood pressure is from high salt. There are many, many, many causes. But it's sort of a silent killer. And when your blood pressure goes up and it's untreated, it affects your heart, it affects your brain. There's some evidence it can affect the kidneys also. So it's so simple to treat and know about. It's like, it's a no-brainer to know what your blood pressure is and to make sure that it's normal. And if it's not, you should see a doctor about it. Now, the reason for also knowing the time of day is because that will change not only the type of pill, but when we give a pill. For instance, if someone has high pressure only first thing in the morning at 7 when they wake up, that lasts a couple hours, but the rest of the day is normal, we're not going to give a pill with breakfast because we've missed the boat. We're going to give a pill the night before, so it'll tackle the pressure in the morning. So that's important too. Sometimes people are on a pill and they can't either get or they don't want to get another dose, and they'll cut the pill they have in half. I'm against cutting pills, even though many doctors will suggest that, because they have a coating on the outside. And that coating causes the pill to be absorbed at a certain rate and last a certain length of time. If you cut the pill, you're getting rid of the coat and you're immediately exposing your blood to that dose, and the dose won't last as long because it's going to be metabolized more quickly. So in general, don't cut pills. Try to get the right dose, even if it means you have to stop using the previous prescription. Not just blood pressure pills, all pills. What else does the kidney do? The kidney prevents what we call anemia. Anemia is due to the fact that we have red cells floating around, red blood cells that carry the oxygen in our blood because they have what's called hemoglobin. And there's a certain number. And they're made, though, in what we call bone marrow. So, when you eat a chicken bone, inside the chicken bone is bone marrow. You're actually eating the red blood cell producing factory. That's where the cells are made. But the bone marrow only knows how many red cells to make every day if it receives a hormone called erythropoietin that the kidney makes. So it's a complicated system here. The kidney senses how much red blood cells you need. It sends out this signal, not a signal, it's a chemical called erythropoietin. It gets to the bone, and the bone then knows how much blood to make. And people with CKD 4 and 5 get anemic because the kidney stops making enough of this hormone. Has nothing to do with potassium, has nothing to do with nitrogen, has nothing to do with the filtering. This is a hormone that comes out of the kidney cells into the blood that regulates whether we're going to get anemic or not. So people on dialysis often need to get erythropoietin artificially. You might have heard of Epogen. This is how Amgen became a multi-billion dollar company. Erythropoietin was cloned many years ago, and we have this artificial erythropoietin that patients get. The other hormone the kidney's responsible for making is called 125 vitamin D. Now, what is this? Well, vitamin D, as you know, creates a healthy skeleton, makes our bones healthy. The vitamin D you get in the drugstore does not work on your bones. It's inactive. It's not the active form of vitamin D. It's called 25 vitamin D. So when you're on 1,000 units or 2,000 units a day, yes, you need it, but not because it's active. It's turned into an active compound by the kidney. The kidney takes the stuff you buy in the drugstore and changes it chemically into the active form. And it's the active form that then keeps your bones healthy. So if you have kidney disease, you're not going to be able to take the 25 vitamin D and turn it into 125. And we have to give that sometimes to patients also artificially, depending on their bones and their calcium and phosphorus chemistry. So two important hormones, erythropoietin and 125, or the hormone is, or the enzyme is called 1-alpha hydroxylase, but it creates the 125 vitamin D. So two important compounds would be a better way of saying it, erythropoietin and the 125 vitamin D. And that's why, as I was alluding to before, we don't take out the kidneys of someone who got a kidney transplant because they might be making enough 125 vitamin D and erythropoietin, or at least some of each, so we don't have to give as much therapeutically. What about research? Well, before research, I just want to give you an idea of the deaths from kidney disease per year compared to cancer. Intuitively, people might think cancer is far, far above kidney, and that's just not true. The number of deaths from kidney disease, 100,000 a year, exceeds breast cancer by 2.5-fold. You'd never know it. Prostate cancer, it's about 3.5 times as much. It's twice as many deaths from kidney as colon cancer. The only cancer that exceeds kidney is the lung, and it's not far above. So the deaths from kidney disease exceed all cancers. But despite that, kidney research is severely, severely underfunded. This shows you the dollars spent per patient per year with these different disease entities. Look at the kidney. It's minuscule. Heart, $61. This is per patient. Cancer, $568 per patient per year. And HIV/AIDS is $3,000 per patient per year. So there's no logic to this, and we can get into this another time, why this country spends so little on kidney research is a whole topic in and of itself. There is an interest in innovation just because hemodialysis and peritoneal dialysis have been around for eons. I mean, hemodialysis was invented in Nazi-occupied Germany and the Netherlands and during World War II. And really, even though the machine is prettier, there's some bells and whistles that have been added, it basically is the same. Peritoneal dialysis came to the fore in the 70s, as I mentioned, and really has remained the same. Again, some changes, but they're cosmetic. So the future is going to give more options to patients. Xenotransplants, which are the transplant of another species into a human. You might have seen today that Mass General transplanted the first pig kidney into a human. There have been 2 previous pig kidneys used, but those were in brain dead patients, and they were external just to show that the kidney was working. The patients were brain dead, and the family agreed to have the pig kidneys hooked up outside the body. Today, actually not today, a week ago, you can Google it. You'll be able to read about it. First patient where a kidney was transplanted internally, like we do with human kidneys, and we'll see what happens. It's still got years to go. There are a lot of hurdles to go, but this was the first time a pig kidney was put into a human. Artificial kidneys, we've been working on one for a number of years. In the future, people will hopefully have more options to their renal replacement therapy. The goal, obviously, is to stop all patients from needing dialysis or renal replacement therapy in the future. But until that occurs, it's going to be nice to give patients some other options, because people just don't like hemodialysis, especially in the elderly. And the average age is going up and up every decade. Right now, the average age is in the mid-70s, and people just at that age can't tolerate the swings in pressure and the tiredness they feel and the lack of energy on the day of dialysis. As I say, peritoneal dialysis is better, but to do peritoneal dialysis, you have to have good vision. You have to be able to hook yourself up sterilely, as I showed in that picture, and unhook yourself. And many people lose the ability to do that because of visual changes, or just they don't trust themselves being sterile with the gloves and using the iodine. So it requires having another caregiver, either a partner. There's also a machine going all night, and the significant other often doesn't want to sleep in the same room with a machine. Even though it's not loud, it's still something that's going on in the background. And then finally, with peritoneal dialysis, solutions are delivered in a truck to your home, and the ones that have been spent are taken away, and you have to really have a spare room to be able to put all these solutions that are constantly coming and going. So both techniques are not optimal. And of course, with transplantation, which is the best option, you're on immunosuppressive drugs also, which have their own side effects. For instance, people with cancer in the last 4 or 5 years, depending on the cancer, are not given a kidney transplant because the immunosuppressive drugs can stop your immunity and bring out the cancer again. It can cause a recurrence. So there's issues with all these modalities. The artificial kidney that we're creating was actually by GE given this recognition a number of years ago as one of the coolest things on the earth. I'm not sure it's that, but it might be a bit of an exaggeration. But anyway, they came out with that accolade a number of years ago. We're still working on it. This just shows some of the components. This is a CAD or engineering drawing of it, and this is a blown up view, just nothing that will be used in a patient, but just to show all the components. It's the first waterless kidney purification device that's ever been created. You may or may not know, but the amount of water used in dialysis per year is enough to feed all the livestock in the United States. That's how much water is being used. So I think with that, I'll stop there. Please try to keep your kidneys healthy, especially if you're overweight. That's the one thing you can do. I realize oftentimes people are hit with things that they're out of their control. But the one thing we all can control is how much food we eat, and to try to keep your weight, and easier said than done, obviously, but try to keep your weight within what it should be for your age and for your body size, for your body surface area. I tell patients in the clinic, take a picture of or get out a picture of what you looked like when you were 16 or 17 and blow it up and hang it on your wall and look at it. And that should be your target. But as we age, the goal should be not to get lazier and lazier and do less and less. Every year you should be stronger and stronger and stronger if you can. Push yourself. Okay, I think I'll stop there. And I know I went over time, so I apologize. But if anyone has any questions, I think we have a few minutes for questions.
There's a question in the chat. The GFR and the creatinine are reflective in both kidneys. If one is defective, how will you know which one it is?
Well, that's a good question. Usually we assume it's both, but if we need to determine whether it's not the same in both, we can catheterize. It's called a catheter. So the doctor will stick a little tube into your bladder, and then there's 2 tubes coming into your bladder, one from each kidney. They'll stick a tube up into each bladder and measure the into each ureter, excuse me, and measure the creatinine and the GFR from each kidney. So that's done usually when people, let's say, have a stone in one kidney that's blocking it, something that's affecting things differently, or a tumor on one side blocking the outflow of the kidney, which I didn't talk about. There are rare instances where they'll want to know whether there's a difference, but usually, unless there's a very good medical reason for assuming a difference, it's a very, very good bet that the function is the same on both, and that it's declined equally on both. Because that's just typically what we see empirically. Any other questions or anything that was
I
confused?
have, I have a question. The nephrologist has told my husband that his sodium is too low.
Yeah.
So he put him on he used to drink up to 100 ounces of water a day.
Sure.
So now he has put him to 45 ounces, including everything that he drinks, and coffee and milk and whatever that is.
Yes.
Is this going to affect him, his kidneys, not having water, that much water?
No, so the kidneys have an excessive amount of water normally, and you'd have to go down to like, a tiny little shot glass to get into trouble. So no, I mean, the amount of water in your body depends on how much you drink and how much the kidney gets rid of. If the kidney can only get rid of a certain amount of water, if you keep drinking normally, you're going to blow up with water like a balloon. So unless they can increase the amount of water coming out in the urine, which we do in people without kidney disease with diuretics, that's why we give a diuretic to make the kidney get rid of more water. If you can't make more water come out, if you keep drinking, you're going to have a difference between the two. So if you drink 2 liters and you only pee out 1 liter, you're going to gain a liter. That's a kilo. You drink 3 liters and you pee out 1 liter, you're going to gain 2 kilo. You're going to retain that water. So the retention of that water leads to the drop in the sodium. The sodium, it's not that you have too little salt, it's that you're diluting out the sodium. The sodium is a reflection of retaining too much water. So you have a choice. It's like you can think of the sodium as your bank account, how much money you have in the bank. And if you spend less and put in the same amount, you're going to have more water or more money in your bank.
Okay.
So if you spend more and put in the same amount, then you'll get rid of money from your bank. So this is the situation you have to think of is the water is like money in the bank. And
Okay.
your husband is spending too little money. So he's putting in the same amount of money, but now the money is accumulating. But now it's not money, it's water. So the only way to do it if he's accumulating too much is to cut back on the intake side.
Yeah.
I hope that
Okay.
makes sense because the goal is to not let him accumulate water in his body. The sodium concentration is an indirect assessment of how much water there is in his whole body. We don't have a way of measuring that directly, but we use the sodium in the blood to give us a rough idea of that. And the fact that the sodium is falling means that he's holding on to too much water just because his kidney can't get rid of it. You would be able to get rid of it. There's many reasons why the kidney can't get rid of water. It could be kidney disease itself, could be heart problems, could be liver problems. There's many reasons why the kidney can't get rid of our water intake. Normally, you drink a liter, you pee a liter. You drink 2 liters, you pee 2 liters. Kidney can get rid of up to maybe 11 or 12 liters a day. Imagine that, 6 2-liter Coke.
Oh my God, so much.
Yeah.
But your husband has a defect in the ability, which is common. I don't know his story, but if he has kidney disease, the kidney can't get rid of water normally. And to prevent the water from building up, which it will, if the intake is more than the output, it's in and out, in and out. That's what you have to think of it. In and out. They have to match. If the out is too low, then you got to make the in lower to match it. So don't worry about the kidney being affected by the intake. It's way, way above what the kidney needs.
Oh, okay. Okay. Thank you. So he has the creatinine 1.19 and the GFR at 59. Is that almost no?
How old is he?
He is 88.
Ooh, that's good.
Almost 88.
Yeah. So, I mean, that question then comes back to what is the normal eGFR or GFR in an 88-year-old? And it can be 60, 65, so if he was 30, yes, he would have, a more significant impairment from what it should be, but his normally should be in the 60s, 65, 70, in that range, maybe a little lower. So the fact, and remember, the eGFR is an estimate. I keep saying that over and over and over.
Yeah.
It's an estimate. So not you personally, none of us know what it really is. But if it's in the 50s, it could be 60, it could be 48. I mean, it's unknown. A creatinine of 1.2 for an 88-year-old is nothing to worry about.
Right.
Nothing to worry about. That's,
Really good.
that's not bad at all. I wouldn't worry.
Oh,
Now that brings up the point though, why is he not able to get rid of water? Because a creatinine of 1.2 with an EGFR in the 50s, 60s, 70s, whatever, you should be able to get rid of 4, 5, 6 liters a day. And the fact that he can't get rid, I mean, I don't know how much he drinks. Let's say a 2-liter Coke bottle, how much is he drinking a day? Half of that? Half of that?
yeah, approximately, I would say right now I measured it that he doesn't drink more than 45 ounces.
No, I'm saying normally. If you add up the soup, the water, the tea, the coffee, just normally, how much would he drink? Is it about 2 liters, 3 liters?
No, well, yeah, about 3 liters, I would say.
Before, not. Yeah, I mean, someone with a creatinine of 1.2 should be able to easily
Yeah, right.
pee out 3 liters a day.
Mm-hmm.
It's not.
He had open heart surgery last in December of 22.
Okay, so that then explains it more. As I was saying, if you have heart problems or liver problems, that can also be a reason why you can't get rid of water. So his kidney function doesn't seem to be the culprit or the cause of why he can't get rid of water. It sounds more cardiac or heart to me. But it's the same thing. If the kidney cannot get rid of 2 or 3 liters because the heart is not pumping enough to get the blood, whatever the reason is, it's heart, then you have to cut back on the intake side. If you don't cut the intake down to what the kidney can do, you're going to blow up like a balloon with water and his sodium is going to drop. So I wouldn't worry about it.
Okay. All right. Thank you so much.
Anyone else have any questions that weren't clear?
Yeah, I do. Can you hear me?
Yes.
Okay.
Jane.
Hi. Yeah, I was at the last meeting and spoke with you on the phone after. I'm getting all my numbers together for you. I will be giving you a call and everything with that.
Sure.
But I have a question. One thing you said, the kidneys make 125 vitamin D now, or converts D3 to that. I'm a little confused. So if I'm taking a D3 supplement, which I should be, I haven't been so good about it. Like he wants me to take like I don't know, like 30,000 a week, something like that, 35,000 a week of D3. Like you say, if my kidneys aren't working well, it's not going to get converted to the usable 125 vitamin D.
If you don't have kidneys that are able to convert the 25 hydroxy vitamin D to the active form, then you will not have the active form. It's really the kidney that is responsible for that. Now that can be uncoupled. That can be uncoupled. That ability to convert the 25 hydroxy to 125 is uncoupled from what your EGFR is and your creatinine. It's not a filtration, not a filtering issue. The cells make do the conversion. You can have.
It's not a filtering. Okay.
That's why I say the kidney has hundreds of different functions that are uncoupled. It's totally nothing to do with your I mean, there's in general some sort of global trend, but in a given person with an EGFR of 40, to say that the ability to make 125 vitamin D is impaired or not impaired is absolutely irrational and impossible.
Okay, so it's not tied to your high creatinine or your low GFR.
In a global sense, and when your EGFR is like 10 or 15, the cells themselves are likely destroyed. It isn't just the filter. It isn't just the filter that's affected. So if I had to bet, I would say, yeah, that person's 125 vitamin D production will not be normal. But between that and normal, they're uncoupled to the extent that you can predict. It's just a separate, just like the erythropoietin anemia story.
Right.
They're different. The kidney you should not think of as having one function. It has hundreds and hundreds of functions like your brain. I often say the kidney is the most complicated device in the universe. In a certain sense, it's more complicated than the brain.
Wow. All right. My husband had a question. He just had to leave right now to go to a meeting, but He wanted to know if drinking alcohol is bad on the kidneys, like it, I mean, he's not an alcoholic, but he used to like to have maybe a
No,
4-ounce glass of wine a day, but now they told him not
nothing,
to.
well, nothing that anyone has found. I mean, wine, there's the French paradox.
Yeah.
Why do people in France seem to have so little heart disease? And some people think it's the resveratrol or compounds in the wine that actually protect your blood vessels. But in general, no. No one has ever shown that alcohol does anything to the kidney other than it does to other organs. I mean, chronic alcoholic disease, the liver by far is affected.
Yeah. Mm-hmm.
It's not a cause of CKD.
Oh, okay.
And it does, no one's ever shown that it makes your CKD stage worse.
Yeah, well, I know he did go off of it because his amylase and lipase, and which are what pancreatic enzymes, those were going way up crazy.
From alcohol, that's a separate story.
Yeah, I know. So he went off of it. He's wondering if it affects the kidneys, though.
I have a question. I heard that it's better to eat more of a vegetarian type diet, just eat a little meat. As you said something before about the nitrogen, which is released, which is.
So that's a whole controversial area. It's still being studied. And, every day you go on the internet, you'll find different studies. In general, sort of culturally, people are pushing vegetarian type of diet. So it's almost a self-fulfilling prophecy that people will say protein coming from vegetables is better than meat. I'm suspicious of all those studies until they're actually done well. And there's no good study showing that. There's sort of two issues. One, how much protein should you eat? The second question, and that varies with CKD stages and is controversial. That's topic one, and is a whole lecture in and of itself. And then the second topic is, for a given protein intake, what's better to have, meat or non-meat derived protein? There are certain things that are lacking in non-meat protein, but in general, many people are studying that question, and there isn't just effect on the kidney per se. It's a question of what the diet is doing for the heart, right? Because you can't have a diet unless your heart is in good shape. What does it do to the mind? Are you going to get dementia? All these kind of questions are important because everything feeds back on everything. You're not going to look after your kidneys, unfortunately, if you get Alzheimer's, someone else is going to have to do it for you. So all these things are not so simple. And unfortunately, in the press and in things you read, even the physicians themselves, everything is significantly oversimplified. But in general, it's an active area of study. It's a very hard study because the question is, how long do you put the people in the two arms of the study on the different diets? It isn't just protein per se, but what type of protein? Is fish protein the same as meat protein? Is vegetable protein the same as protein from seeds? And these questions are very difficult, and that's why they've never been answered.
Oh, okay.
So there is no easy answer. I don't want to make it more complicated, but in general, to me, the more important question is, what is the end result of what you're doing? What is your blood pressure? What is your hemoglobin A1C? Hemoglobin A1C, for those that aren't familiar, is the average, is a compound that gives you the average of your blood sugar over, let's say, the month, as opposed to measuring your sugar, your blood sugar. So what's your hemoglobin A1C? It should be in the 4s. What's your LDL cholesterol? It should be low, or you should be on a statin. What's your homocysteine level? Been shown to correlate with blood vessel abnormalities. What's your weight? What's your bone? What are your bones like, so that you don't, when you're in your 80s, you prevent you from walking? What's your arthritis like, preventing you from doing exercises and keeping your heart healthy? All these kind of questions are much more important. What's the end result of whatever you do is much more important than these things on the input side. I would say if it was known that if you ate a steak 10 times a day, all these numbers would be perfect. I'd say keep eating the steak 10 times a day. So it's really not what you do, it's what the result is. That's why it's very important to monitor the things you can monitor yourself, And also make sure you're getting your blood tests done, especially when you get into your 70s and 80s and 90s. I mean, the trouble starts in the 50s and then no one looks at it. You know, people aren't caring or thinking about it until the trouble starts, unfortunately. But at least, you know, you should know what the weather report's going to be. The weather report being your blood tests, as much as possible, and your urine.
Okay.
So that's sort of my philosophy. Not
Well,
not-
your A1C is supposed to be what? Your
your
A1C?
hemoglobin A1C should be in the high 4s, low 5s. If it's not,
Well,
you could be becoming pre-diabetic. Most
Oh,
common would be you're overweight and insulin's not working as well as it should.
yeah, so like if it's 5.7, that's too high, right?
Well, they'll give you the normal for your age. I don't remember the exact.
Oh, I don't know, yeah,
But
okay,
you need to focus on that, just like the size of the shoes you wear.
yeah,
You should know your hemoglobin A1C. You should know your creatinine. You should know your LDL cholesterol with your eyes closed.
mm-hmm,
You have to know that. You should know what your weight is, know what your blood pressure is. You'll add
Right.
years to your life. You know,
mm-hmm.
the human body is a machine. It's just a machine. I mean, people look
Yeah.
after their cars better than they look after their bodies.
I'm laughing. It's not funny, but it's true.
Yeah,
It's-
unfortunately.
Yeah,
Thank
yeah.
you so much. Thank you.
People are
It
so
was-
worried about what type of gas they put in their car,
mhm.
shovel all sorts of garbage into their mouths. I mean, you can do that when you're, 10, 20, 30, because the body
Right.
can tolerate everything and can compensate. But, as you get into your 60s, 70s, 80s, 90s, and 100s, you have less backup systems. So you have to, with your intellect, decide what to put in.
Mhm.
If you're not sure, don't put it in.
Okay.
Okay, that's good advice. Thank you so much.
Thank you so much, Dr. Kurt.
You're welcome.
Yeah, really appreciate you.
Appreciate it.
Stay healthy, everybody.
You